Dear Nephrology colleagues, welcome to the live 2021 Nephrology Campus. My name is Peter Stenvinkel. I am a professor in nephrology at the Karolinska Institute in Stockholm, Sweden, and I co-chair this nephrology campus with Professor Christoph Wanner from the University Hospital of Wuerzburg in Germany. So under this format, we present 18 webinars about current trends in nephrology. And today it's an honor for me to introduce webinar number 5. But before doing so, there are some housekeeping rules. You as an attendee, you are automatically muted and invisible during the talks, but you should feel free to ask questions via chat function in GoToWebinar in the right bottom corner. So now it's time for me to introduce the speakers of this 5th webinar. And I would like to start with Dr. Charles Chazot, who is the medical director in NephroCare in France and Fresenius Medical Care, and Dr. Jule Pinter, working at the University Hospital Wuerzburg in Germany. And the presentations today will be about sodium, volume, and pressure control in stage 5 CKD dialysis patients. So now, Dr. Chazot, it's an honor for me to introduce you to this talk. And you will talk about cardiovascular disease and fluid overload, potential solutions for pressure control on dialysis. Please.
Thank you, Professor Stenvinkel. And dear colleagues, I want to thank the organizer that gave me the opportunity to share with you some thoughts about fluid overload and pressure control on dialysis patients. I would like to start by reminding you the Clyde Shields legacy. Clyde Shields has been the first chronic dialysis patient treated in Seattle by Professor Scribner. And as soon as he started hemodialysis, he developed malignant hypertension. Professor Scribner decided to ultrafiltrate Clyde Shields, and this was efficient to treat the hypertension, and Clyde Shields lived 11 years under chronic hemodialysis therapy. So we can say that fluid overload and related high blood pressure have been the main life-threatening complication of the first chronic dialysis patient. Recently, the KDIGO have released the guidelines about blood pressure and volume management in dialysis. And I have selected a number of statements. Based on existing evidence, definitive recommendations regarding blood pressure treatment targets cannot be made. Extrapolating from current general population hypertension guidelines may be reasonable, but such guidelines do not account for differences in cardiovascular risk in dialysis patients. Efforts to develop best practices in managing blood pressure and volume in dialysis have been hampered by an absence of widely available, accurate, and objective measures of extracellular volume status, and as well as a lack of high-quality evidence. And last but not least, qualitative data suggests that suboptimal blood pressure and volume management negatively affect quality of life. This is really important because, as far as I know, it is the first time that quality of life is associated with volume management. I want to remind you that fluid excess and cardiovascular remodeling starts early in CKD. This is a study by Marie Essig, and you can see that fluid accumulation starts early during the CKD, and this is related to left ventricular hypertrophy, left ventricular mass. This is the cardiac remodeling associated with accumulation of fluid. And also, there is an increase of pulse wave velocity in patients with early CKD, and this is the marker of vascular stiffening the vascular remodeling associated with fluid accumulation. In dialysis patients, it has been shown that congestive heart failure is found up to 25% of European dialysis patients and up to 46% of hemodialysis patients. And hypertension is found in more than 50% in more than 50% of hemodialysis patients. So we can see this burden that is high in these patients, and it is related with outcomes. And you can see that fluid retention associated with hypertension are important to develop vascular stiffening, increasing the pressure overload that leads to adaptive left ventricular hypertrophy, maladaptive left ventricular hypertrophy, leading to myocyte death and heart failure. So we can see that this burden is really important related to this complication. Of course, we know how to cure and to decrease high blood pressure, and we can do this by probing for dry weight. And a randomized controlled trial called the DRIP study by Rajiv Agarwal has shown that when you decrease voluntarily the dry weight of the patients, you have an important decline of the systolic and the diastolic pressure compared to the patients who remain on standard of care. So we can correct high blood pressure removing fluid. But the question is high blood pressure in hemodialysis patient always related to fluid overload? This is not the case. In this study by Peter Wabel, fluid accumulation was measured with bioimpedance. And you can see here that 36% of patients who had high blood pressure were considered as normal hydrated. And recently, Francesca Maramassi, in a very recent study, stated that and found that 86% of hemodialysis patients with apparent resistant hypertension were not fluid overload. So in these patients, we might be very cautious removing fluid. But one of the other question is, what is more important? Is it normal hydration or is it normal blood pressure, or both? Professor Zoccali has addressed this question in this cohort study in more than 22,000 incident hemodialysis patients that were studied for 1 year. And you can see that in patients with normal blood pressure, that was the reference, in these normal hydrated patients, an increase of blood pressure or low blood pressure were associated with an increased risk by less than 20% of all-cause mortality. But as soon as fluid overload was present in these patients, even in these with normal blood pressure, between 130 to 160 millimeters of mercury before dialysis, you can see that there was a significant increase of 51% of increased risk of dying. High blood pressure was associated with 62% increase of risk of dying, and low blood pressure because of heart failure had a much more important risk of dying in these patients. So according to these data, fluid overload appears a more significant risk of dying than blood pressure itself. And when we remove fluid, we may improve cardiac function. I like this small cohort study in 12 patients who started hemodialysis with an ejection fraction of 31%. And you can see that after a few weeks removing fluid, the ejection fraction increased significantly to 50%. So removing fluid improves the cardiac function. And we have shown that the BNP that is secreted because of the stretch constraint on the heart is decreased in incident dialysis patients, and this progressive decline of BNP is associated with the removing of fluid. But we know now that fluid removal rate is associated also with mortality. And this comes from this famous study by Jennifer Flight, and the threshold of 13 milliliters per hour and per kilogram was associated with overall and cardiovascular mortality. In our experience with long hour dialysis, we were able to show a lower threshold about around milliliters per hour and per kilogram. So I think that removing fluid is associated with a sort of continuum of risk in these patients. And we know that this is related with this concept developed by Chris McIntyre, that is the intermittent dialysis circulatory stress, because removing fluid is associated with myocardial stunning, with brain pulses, with gut ischemia and release of endotoxin, with the decrease of residual renal function, with the increase of the risk of fistula clotting, and also with the development of wounds in patients with peripheral vascular disease. So what can we do? What can we do to manage the fluid and to avoid intradialytic hypotension, that is the main side effects of removing fluid? The DOPS study has shown that you may, when you have in your unit a driveway assessment protocol, you may decrease the all-cause mortality and the cardiovascular mortality. In your unit, in the unit where orthostatic blood pressure is measured, there is a decrease of cardiovascular event and of hospitalization rate. And also in units where a lower dialysate temperature is used, there is a decrease of cardiovascular mortality that is significant. However, when you use tools like the online volume indicator, there is no improvement of the patient, and there is even a risk of increasing hospitalization. So my conclusion are, yes, definitely volume first. Volume is a very strong uremic toxin, and this has been stated by a number of chief medical officers of dialysis chain a few years ago. We must never forget the session time, the frequency, and the low salt diet. They are the basics to manage fluid in these patients. Of course, I strongly agree with the need of individualization that is required for volume management in dialysis patients, as stated by the CADIGO. In my opinion, we have to transform multi-frequency bioimpedance from innovative technology to essential tool for precision medicine in volume management. And of course, more evidence are required, and we have to work on this. And maybe the zero sodium diffusion tool that will be accessible now on dialysis machine will help us to better handle sodium balance. That is a promising tool, but this is for the next speaker. Thank you very much for your attention.
Thank you, Charles Chazot, for this excellent lecture. And for you out in the audience, I would like to remind you that you have the opportunity now to ask your questions. So please use the chat function. Now I would like to introduce the next speaker, Dr. Jule Pinter. It's a pleasure to see you here. You are in Wuerzburg, I recall, and you will talk about sodium control on hemodialysis. Please.
Hello, Professor Stenvinkel. Thank you for introducing me, and thank you to the organization for giving me the opportunity to talk today. I would like to share with you the topic of sodium control in hemodialysis. In this short webinar today, I'm going to discuss in the next 10 minutes 3 topics. The first being the pathophysiology of sodium balance and the net removal on hemodialysis, and the evidence that we have on dialysate sodium. In the next topic, I would like to discuss the contradictory clinical practice and touch on the need for research. And last but not least, put any solutions for sodium control to improve patient mortality into perspective. So if we step back for a minute, all what we strive for is the best survival for all of our patients. And when you lose kidney function and chronic and end-stage kidney disease, and you become dependent on dialysis, then you lose the kidney as central regulator for sodium and volume control. This means inevitably sodium will accumulate in the body. The famous working group by Tietze and Carnot has very nicely illustrated and rediscovered that we do not only have osmotic active sodium responsible for tonicity and hemodynamics, but that there is also a third compartment of osmotic inactive sodium, which correlates with metabolism, is stored in vital organs such as the muscle and the skin or vessels, and which is disease relevant. However, this is not completely understood yet. And what we strive for is outcome, but still, though technology has improved, the mortality and morbidity in hemodialysis patients is still astoundingly high. Over 50% of hemodialysis patients die due to cardiovascular disease, and this is, as we know from the first randomized controlled trials in the early 2000s in the New England Journal of Medicine, not atherosclerosis, but atypical cardiovascular disease. And Charles, in his first talk, has very nicely illustrated and explained the links between chronic volume overload and maladaptive left ventricular hypertrophy. And we also know that there are strong links between sodium accumulation and left ventricular hypertrophy. Due to the shortness of time, I can only briefly mention various associations such as a positive gradient leads to increased thirst, increased weight gain between dialysis, increased chronic volume overload, and then to more cardiovascular disease and then more prominent death. And when you lose kidney function and the machine replaces sodium and water, we need to look at dialysis delivery. Unfortunately, though technology has improved, hemodialysis does not remove all the sodium that is accumulated in the body. You basically have, or the patient can leave dialysis with a positive, a isonatremic, or a negative sodium balance, depending on how much fluid you remove. Most of the sodium is removed through convection, so through the ultrafiltration volume, but you also have a percentage, like around 20%, which is removed by diffusion. And as we don't all around the globe have different machines, it's difficult to exactly control how much sodium is removed during one session. And in this talk or in the next minutes, I would like to speak about dialysate sodium as a modifiable and easy to alter mode of delivery around the globe, which could be a potential mode of prescription for nephrologists. And so in the next minutes, I would like to speak about its evidence. In 2019, a Cochrane review was published by Dunlop, who looked at the randomized trials that has been published so far and investigated low, intermediate, and high dialysate sodium in hemodialysis patients. However, only 12 trials with 266 patients could in the end be actually evaluated in this meta-analysis. We don't have any hard clinical endpoints yet or results from hard clinical endpoints, and these were only surrogate markers. So overall, the evidence that we have on this potential solution and mode of delivery is low and inconsistent. Most of the trials were published before the 2000s or in the early 2000s, but what we can see here as you look on this forest plot is if you look to the left with the low dialysate sodium, to the right with the higher dialysate sodium, that potentially an active decreasing, an active lowering of dialysate sodium leads to less interdialytic weight gain, to improved blood pressure control during the session, but also increases the risk of intradialytic hypertension. And we all know that this is what we want to avoid. So even though evidence is low, we could say that nephrologists are very experienced in treating their patients. So they must actually know what is best and how do they actually use this mode of prescription. We therefore took a look at one of the most current registries that we have currently available in Europe and in countries in Eastern Europe. It's a snapshot that you can see here from the Euclid registry. About 53,000 patients are in this registry in 19 countries. You can see these countries on the y-axis, from France to Hungary, Italy, Poland, Russia, up to the UK. And on the x-axis, you can see the dialysate sodium from 134 to 143. And the next picture, you don't have to understand, but I want you to take two main messages from this mixed picture. So if we leave the blanks or the outliers, then 50% of nephrologists treat their patient with a dialysate sodium of 138 and 15% with 140. But then if we look into further detail into the different countries, then the prescriptions vary. So for example, if we pick Italy, then we can see that they start to prescribe from 138, but they also use 140 or even 142 in most of their patients. Unlike other countries like Russia, in which most patients are dialyzed against a very low sodium, dialysate sodium. So they even use 135 in 19.4% of their patients, 136 in 25% of the patients. And so this leaves us with an inconsistent taste. And it clearly implies the need to investigate and the need for research. We currently don't have a standard of practice worldwide, and we need research and trials that investigate default prescription versus individual sodium profiling. And now machines have been developed with an isonatremic profile so that the sodium leaves dialysis with the same sodium than he left. And this has there has only been some small evidence on this. There is one trial worth mentioning that takes the topic of default dialysate sodium into account, which I would like to briefly introduce you and is worth mentioning. It's a global cluster randomized trial currently underway on 4 continents. And it is a comparative effectiveness trial that investigates whether a lower 137 dialysate sodium versus a higher dialysate sodium of 140 has an impact on cardiovascular mortality. And a high amount, 414 dialysis centers will participate in this trial. A third has been randomized so far. And in the next years, we will gain insight on whether dialysate sodium and the active but small decrease could actually improve patient outcome. So now at the end of this webinar, or coming back to clinical practice, what we have to keep in mind, and what Chaz very nicely illustrated and explained, is that if we want to improve sodium control, we have to look at the whole picture as practitioners. And this implies the clinical management, the probing for dry weight with our traditional parameters and our technological instruments, very new instruments like bioimpedance spectroscopy, and the patient, what we can see on physical examination with his vital signs. And hopefully in the future, further advanced analytics will help us to improve the mismatch that we currently have between the patient and our prescription parameters during the session. Charles very nicely explained or illustrated this trial, the DOPS trial, that looked at various aspects on how patient outcome can actually be improved. So this was an observational studies, and we're talking about associations, but we can clearly see that dry weight management and volume management is associated with better all-cause mortality and cardiovascular mortality. And here, I would like to stress one point of caution. We don't have any randomized trials on this, but in these observational data, we can see some hazard that sodium modeling and individual prescriptions on sodium profiling are associated with an increased hazard, so some type of harm. My take-home message for today is that if we want to improve patient care, then we need to take the volume management into account. And if we have and manage to put the dry weight right and control for volume, then inevitably sodium control will also be improved and patient mortality will be reduced. The take-home messages for today from this webinar is that through the loss of kidney function, sodium inevitably accumulates in stage 3 to 5 chronic kidney disease. We don't only have osmotic active, but we also have an inosmotic part, which is disease relevant and has to be better understood in the future through more research. That sodium is mostly removed through ultrafiltration volume and convection, but also through diffusion. And that dialysate sodium could be a potential mode of delivery that could actually be a prescription, a mode to improve patient care. However, its evidence is inconsistent, and we have a large clinical outcome trial underway that actually looks at the default dialysate sodium. And yet solutions for sodium control in clinical practice still need to be researched. Thank you for your attention, and I look forward to the questions now.
Thank you, Dr. Pinter, for this really interesting lecture. And we have received many interesting questions from you in the audience. And we will now have time to go through these questions addressed to Dr. Pinter and Chazot. So the first question is for you, Charles. Do you think that we can and should make use of consumer-grade bioimpedance monitors, especially in the home hemodialysis setting?
Well, that's a very good question. I think if you go to the supermarket, you can buy scales that have bioimpedance integrated in the device. But of course, they are not designed for this particular situation of dialysis patients. Of course, I think that now the bioimpedance has become a reliable tool, and it is part of the decision of the medical decision for the volume management. And of course, in the home hemodialysis setting, it could be interesting to have availability of bioimpedance. However, in my opinion, I am not sure that this is really important, because in our practice of home hemodialysis, usually we ask the patients to come back to the unit at least once a month, and it gives us the opportunity to measure the bioimpedance at that time when the patients come back to the unit. And so to have it at home, I am not sure it is a key factor. However, if it becomes available, of course, it will be part of the management.
Thank you, Charles. Can I have the next question, please? Oh, this is a question for both of you. How reliable is the inferior vena cava diameter and its collapsibility measurement for assessing volemia? Who will like to
Ladies
start?
first.
Okay.
Ladies first.
Well, I think it's one way, one instrument to help and improve volume control. But often in clinical practice, even though you have the ultrasound and you can step to the patient's bed, it has proved not to be very effective. And I would say that, as we've just discussed, bioimpedance spectroscopy offers a offers more the opportunity to reliably assess the volume status of the patient and optimize the dry weight. Charles, what would you
do you
say?
agree?
Yes, I do. In my opinion, every method that asks the patient to remain after dialysis, because we have to perform this measurement after dialysis, is a big problem for the patient because they want to run away from the dialysis unit. So this is the first limitation. And the second limitation, I am not aware of strong studies that rely the collapsibility of the vena cava and the outcomes of the patients, opposite to what we have now with bioimpedance. So, of course, it depends on the expertise of the people who are of the doctors that perform these measurements, and some are probably very, very good and very reliable. But I am not sure that it would be a priority in my practice.
Thank you. Next question, please. And this is for you, Jule. Why are there so big differences in sodium dialysate use between different countries? Do you have any speculation about this?
That's a great question. I've been also pondering about, and we don't have any reliable answer on this yet. So we don't. One problem is that the lack of evidence, and that we only have up to this point surrogate endpoint studies with no hard clinical endpoints. The other thing is that apparently there are strong cultural differences that may also play into account. We know, for example, that Russia has rather cold temperatures in comparison to Italy, and that also diets are very different if we compare Eastern or Southern European countries. But this is all association speculation. We don't exactly know why these differences are so big. And even if you look into the DOPS trial that said, okay, let's stick to 140, and then we have that expert-based recommendations to actively lower dialysate sodium because it improves weight gain and improves blood pressure control, then these are contradictory, and nephrologists, based on their experience, seem to pick what they think is best for their patients. But because we don't have a lot of registry trials and in between country comparisons, nephrologists are somehow stuck to themselves in their decision making about this.
Great. Thank you for this answer. Any more questions? Yes, this is for you, Charles. Are there any studies or results about fluid overload in dialysis patients concerning a different type of medication during the treatment of high blood pressure?
Well, I don't know if I understand very well the question. I think so. We have a large availability of antihypertensive drugs that can be dialysis patients. Of course, we have the what happens during the dialysis with these medication, but their relationship with overload. I would insist that in some patients who keep some residual renal function, the use of diuretics may be helpful in these patients. So, however, I think we lack of evidence and we lack of large studies showing the efficiency of these of diuretics in dialysis patients, even with profound, even if there is only a small diuresis. And so this is also a field for clinical research, in my opinion.
Okay, thank you. And next question, please. Again for you, Charles. Do you think future KDIGO guidelines will line out how to properly individualize fluid control measures for CKD patients?
Well, this is the question for the future experts. And I am not, of course, what is important in fluid management? Fluid excess is not so easy to assess in dialysis patients. We have clinical signs like blood pressure, but I have shown that they are not hypertensive dialysis patients are not always fluid overloaded, and we have edema at clinical exam, and but we have also assessment of brain natriuretic peptide that can help us to assess the fluid overload, and bioimpedance, of course. So we have a number, and vena cava diameter for those who for which when it is available. So individualization, in my opinion, relies on the use of these different possibility to assess the fluid overload, and it is the combination of these tools that will help us to individualize the fluid management. So, what will the future KDIGO will say? I don't know, but I would recommend to combine all what is available at the moment, as far as we lack the ideal tool. And I think it will be a combination of those to individualize the fluid management.
So Jule, you are a nephrologist of the future. Do you have any additional comments or thoughts about this question?
Of course, the SGLT2 inhibitors popped into my mind. So if we think about CKD patients, not dialysis patients, early CKD versus now late stage CKD, we know from, well, the latest trial, DAPA CKD, and then upcoming IMPA kidney, that there is probably going to be a very strong evidence that SGLT2 inhibitors can probably also improve volume control. And then that next to diuretic management and then a good blood pressure control could actually improve volume control in CKD patients.
Thank you. Next question, please. There are no more questions. So with this, I would like to thank both the speakers and especially you, the audience, for your participation. More questions.
There's a question, yeah.
Yes, I realized that there was another question here. So let's, and this is a question for you, Jule. Adjusting a dialysis prescription for an estimation of filtration rate to prevent fluid imbalance overload. Is that an area with potential which should require more studies?
Adjusting of dialysis prescription for an estimation of filtration rate. So filtration rate, does that imply how much ultrafiltration volume we remove, or what the GFR of the patient is? I think the ultrafiltration volume.
Yeah, I think so too. But maybe the person that asked this question could send an email to you and discuss this AI, or do you have a suggestion how to answer this?
So I think we would probably one thing is that the Resolve trial is underway, and then this will also look at ultrafiltration volume, and so we might get some evidence there in the upcoming years on how patient parameters and ultrafiltration volume are connected. And we know from now currently that we have those thresholds Charles mentioned, so don't go above 13 milliliter per kilogram per hour, or better, even have lower rates of removal or of removal. Just thinking about the future, advanced analytics could probably help us there if we have improved technological backup, that we can actually combine multiple parameters and somehow develop a system that can actually promote or foresee how the patient's volume status will develop. Then we could probably use that in some decades in clinical practice to improve volume control, so that if the parameters of the patients are combined in the machine and it reaches a threshold, then the volume will automatically be reduced, the amount of volume that is drawn per minute. But this is an area of research in the future.
Thank you, Jule. So are there any more questions for the faculty? Yes, one more for you, Jule. Do you think that the removal of sodium during hemodialysis should always be convective, while the diffusive one should always be equal to 0?
I can't reliably answer this question by now, because we don't know yet whether Charles, maybe.
Well,
Any idea?
I think at the moment, the average diffusive part of sodium removal is around 20%. So with the isonatremic dialysis that now will be accessible, it is a good question to wonder what happens if we suppress completely the diffusion part. But this module will allow us to decide what part of the diffusion will be able to apply. We will be able to apply. So I think suppressing totally the diffusion part could lead to some sodium accumulation, because in some patients needs to have diffusion to remove the sodium excess. And so my answer is, we are waiting to know more about these devices, about this device, to know how to use them, and to make the part between convective and diffusive elimination of sodium.
Okay, so again, more studies are needed, as always.
Always.
Yes. Are there more questions for the faculty? Yes, and this is for Jule again. What about the use of hypertonic glucose instead of saline for the treatment of intradialytic hypotension and cramps as a way to avoid sodium loading and preventing thirst? So a very clinically relevant question here.
Very interesting question. To be honest with you, I haven't seen in my clinical practice yet any use of hypertonic glucose instead of saline to treat intradialytic hypertension. Have you experienced or encountered it, Charles?
No, to be frank, no. And I'm not sure that administering high amount of glucose will prevent the thirst. And but I lack evidence for this.
So again, we need more studies. Is there more questions for the faculty? Another one for you, Jule. About sodium control during dialysis sessions, in Russia we pay much attention to online sodium control monitoring by OCM. and we do our estimated sodium 2 to 3 millimoles lower. Do you think this is a good practice?
Well, I think it's the surrogate markers that we have until now are promising that an active reduction of dialysate sodium actually improves patient outcomes. And so I would agree that this is probably, that's also my own hypothesis. But then we also have the DOPS trials that implied that, well, if patients are more vulnerable and more fragile, it might be better to have a higher dialysate sodium. So I think currently we could say an active reduction of dialysate sodium is probably good, but I can't reliably, I don't have the backup of evidence to reliably, but from clinical practice, I would say yes. Charles, what
Do
do
you
you
agree?
think?
Yes, I completely agree with this, and because what we want to avoid is a positive sodium balance at the end of dialysis, and we know that part of the sodium is not has not access to diffusion. So we may use lower sodium dialysate, a bit lower than the natremia, and this will prevent the positive sodium balance at the end of the dialysis. And there was a paper by Moret in 2002, I think, in American Journal of Disease, showing that we, with the gradient around up to 5 millimole, with a 5 millimole gradient, low dialysate sodium, we could prevent a positive sodium balance at the end of dialysis. So to be 2 or 3 millimole lower than the natremia for me is a good practice. Of course, it
Great,
depends
thank you
also of the tolerance.
Yes. I would like to know if there are more questions for the faculty here. Yes, this is a question for you, Charles. Would you recommend to adjust or increase the amount of session or session times to reduce the fluid removal rate?
Of course, of course, this is the key. But everybody knows that we cannot do this in many dialysis units because there are a lot of patients and there are not many space available to perform extra dialysis or to increase the dialysis time. And of course, this is very important. And we know we have indications from the ultrafiltration rate threshold. I mentioned 13 milliliters per kilogram and per hour. And of course, if the patient is constantly above this threshold, we have to convince him to increase the time or even to increase the frequency during the week. So if we have no other possibility for him to decrease his interdialytic weight gain, the session time or session frequency is the only solution to preserve his risk of complications with fluid removal. So, of course, this is the key.
So then I'm curious to know, what is the median session time in your unit, Charles?
Well, that's a good question because I used to in my unit 20 years ago, the average session time was around 6 hours. But to be frank, now time has decreased, and we have standard dialysis at the moment in 30, let's say 75% of the patient, with 4 hours 3 times per week. But in 25% of them, we prescribe long hour dialysis that is more than 6 hours. And so we select, of course, these patients, and these patients are those with large interdialytic weight gain or with severe heart failure. And so in selected patients, we still perform long hour dialysis during the day or during the night.
Yeah. And Jule, in Wuerzburg, what is the median session time?
I would say it's 4 to 4.5 hours. And
Okay.
we've increasingly started to use the bioimpedance spectroscopy instrument that we have now. And if we see that the patient is volume overloaded, we increase the session time. But I tend to also rather stick to above 4 hours than below the threshold of 4. Only if we have acute situations, then, well, we go with 3 hours, but for the chronic patients, definitely above 4.
Okay, so I have learned that there are no more questions from the audience. I would like to thank both you and Charles and Jule for excellent talks and for very excellent answers to all the questions. And for you in the audience, I would like to thank you for your participation in this, the 5th webinar. So now you can look forward to the next and the 6th webinar, which will be in 14 days on November 19th. It will be my co-chair, Christoph Wanner, that will then introduce Professor Dick Detsuv. And he will talk about the clinical decision support system to tailor therapy and improve renal and cardiovascular outcomes using a multiple parameter response score. So see you all on November 19th. Bye-bye.